Dobrze, może zaczniemy od prezentacji tej klatki, bo to... Okay, we will speak English. So you see that, well, the point which will be very important in this procedure, can we focus it a little bit? I will show you, we show you on a photo that looks heavy and not very handy, but in a matter of fact, this system was designed in Bordeaux which is one of the, well, perhaps leader of invention in the world. Well, it is kind of guarantee of quality of this invention. Well, it was already like 10 years ago, this last version, and it was thought to be used in standard ECG procedure. But you know how time has changed. We have more and more 3D systems, and we use less and less X-ray. But it was only exception, as I showed you during the lecture. Still during cryoablation, the X-ray is crucial. And of course, well, okay, that's good. Well, operator can use less fluoroscopy than maybe less experience, but still it's better to see more than less. And you see only when you expose patient for X-ray. And what was also stated during this presentation, our head, it's usually not covered. And exposed for X-ray, radiation. What I showed, the data from the brain cancer, it's really striking. So, okay, it was not proved by randomized trial, but still there is something which we should consider. So, since we want to see more than less, and we want to be protected from the X-ray, we decided to work with this cabin. And okay, so that it was introduction, and the cabin is like this. Maybe well, I don't know if you see. I can rotate. It's a place for hand. There is the special cover, which is sterile from both sides, and it really goes very smoothly. So you really don't need to use too much power, and we do it in most of cryoablation. Of course, well, the weak point here is that it's difficult to do all the stuff with cabin which is necessary for the cryo. So that's basically for the operator, which is close to the X-ray, and the stomach is covered with normal apron, and this is, but still he is far from the source of X-ray, and also covered from this site. So in this way, our exposure for radiation is much more lower than regular. So I think we can start. Can we use less X-ray? The Tomek already started. Now we will go to the transeptal puncture. Please light down. Tomek, proszę im powiedzieć, żeby to światło troszkę...
Ania, zmniejsz światło troszkę. Okej. Półka nie?
Jeszcze nie. Troszkę wyżej tam stół. Nie stół.
So do you have any specific approach for transeptal puncture for cryo procedure? Do you do it differently than for RF, or is it the same site you're aiming at?
Oh, well, basically it's not good if it's too high. But you know, to be honest, well, it would be great to have eyes like they use it in some very advanced center in Poland and also in Prague. But we don't have this.
Musimy jakiś sobie robić. Teraz jest przedsionku. Musimy przyświetlić.
Niech pani poprosi Agnieszkę, ja muszę założyć na głowę te, chociaż nie mam, albo nie, dobrze, już nie. Zaproszę, tak. Is it his visible? Nie, spokojnie pan dostał. Okay. Mamy na 10? Okay. Okay. He's moved a little bit, but okay, Atrial.
Tak, sowa nam się cofała.
Actually, it's not there, but okay, it's still. It's not stable. No. Well, it should be parallel in area to see to.
It's better.
But I think it looks good. Go back to LAO. Okay.
Ja,
Okay, let's see.
It's actually quite inferior in anterior puncture, which actually could be convenient for cryo. So it leaves a lot of space for right inferior organ. Need space in the puncture side to expand the lungs to have some sheet.
So I think it's okay.
4000.
Well, we give heparin.
I koszulkę do wody. 4000?
Okay, za dużo tego światła jest tu.
Ale mi się to nie może mimo.
Tak, się odbija od ekranu, ale dobrze, okej. Dobra, to co? Możemy... Teraz we'll take the balloon stuff, which is not open because of, we have to save money, so it was not prepared before. But in this point, we will give 4,000 heparin, and we will wait for the rest of it. As you see, this cabin it really doesn't disturb at all, and for me it's very convenient. Even I can say that I can rest a little bit, which in age it's also quite important.
Could you please
have
switch
CT
right
scan.
view to the camera, because we still see the...
See you in
Yes.
this cabin, so
Aha, możemy na kamerę.
here you are.
And give the X-ray instead of the atrium, okay? On the right side. Oh,
And the only drawback of the cabin that I see is that you actually have to be standing, right? Because there is no room for legs. Could you sit down there, or it wouldn't be convenient?
No, but Tomek likes to sit down here, and he is completely covered by this plexi.
And still his arms stretched.
I never sit. That's a Bartek custom, which was, yeah. And can you show us the image? Okay, we have on the screen. And you have CT. Have you seen the
We've seen
CT?
the CT, now we know the anatomy, now we are seeing,
Yeah.
we are viewing the X-ray and
But
you
anyway, normally we more often don't use CT scan. We perform just coronary venography or angiovenography, as you wish, and it's what we are going to do now. Okay.
I was asking before whether the patient was awake or under general anesthesia.
It's right now we have conscious sedation, and it's the way how we usually doing this. The cases we've seen before with general anesthesia was just on demand of our guests, but we don't have such a comfort usually. And to be honest, I'm not really sure that it's really necessary. The contact with patient is sometimes very important.
it's true with the cryo, of course, because it's not so probably... sometimes it is painful, but using high doses of opioids, it's really patient can bear this pain that he feels. But there's data on RF ablation that it improves outcome of this RF ablation when it's conducted under general anesthesia. So because some regions are more painful for the patient, and it causes instability of the catheter, and repeated ablations in one spot, and we know that it's responsible for reconnection. So probably that's the reason. But in cryos, not the problem.
No, the only issue here is the temperature monitoring in the esophagus, which we actually don't do because the patient being awake can't stand that. And I believe it's the general problem of our country. Most patients are being done under conscious sedation, but they don't have that probe. And still there is the issue of thermal lesions in esophagus, which could be frequent without monitoring. We don't know that, actually. I don't know if anyone here does cryo under general anesthesia and temperature measurements. No one. So yes, when we did this study,
We even have this probe here.
Yeah, we don't have it
But
either because
Tomek
there is no
said
way we
that-
could use it. But
No,
the
we
study
will
we did
use it.
6 years ago, nearly 10% of people had some lesions after standard cryo procedure. The standard then was twice 4 minutes. So it was more applications than we are doing nowadays, but still it's a considerable number of lesions.
Did you use the first,
showed
the
its
second generation?
images.
Then?
Second.
Second.
And to be honest, we even have probes, but we just wanted to practice a little bit before this workshop. But it happened from a different reason that we did not use it before here on a regular basis. So we decided to not show it because it's not our standard approach, and it's an additional element which we might start. What we keep it, let's see, we try to avoid application below 50 degrees because as I showed you from one of the Frankfurt work, they showed that when it's places with visible lesion esophagus were places with temperature, mean temperature of 55 degrees. So that's something which should be avoided.
So you just use this as safety cutoff, the 55, right? If I
Yes,
understood
not below 50. Practically, we do not allow. It's better to stop and to be on the safe side.
Is this with regard to the left inferior vein or to all veins? Because it's the left inferior which is tricky with this regard.
And also right superior, I think.
Okej, będziemy w takim razie angiografię, wonografię robić.
Okay. That's always problem. How to call it? Venography or angiography? That's.
Okej. A nie będziemy stymulowali cyklem 300, tylko popchniemy trecewnik do komory. Hisa do komory włóżmy i...
Okay, so you're doing a non-selective venography, right, with pacing, if I
Yes.
get you correctly.
So, let's see how it is. Okay. Can we?
Chwilkę, jeszcze sekundkę, bo ja muszę wypełnić napisanie.
Okay.
Stymulację musimy sprawdzić, czy działa. SISA, sprawdzaj na stymulację SISA, czy działa.
Tak, tak.
600, tak. No to poprawmy SISA.
It's 2.1. Okay.
Spróbuj teraz.
Pani Aniu, może więcej prądu, co? Dobra, it's okay.
Okej. Cykl 300. Stymulujmy. Stymulacja. Okej. Stop. Stop.
So,
Bardziej do tyłu.
You can see nice appendage and shadows of the two
very nice.
lateral veins.
Yes. You're right. And maybe like this. Okay, can we stimulate?
Stymulacja.
Again, it's.
Stop.
Dobra, jeszcze raz.
Też. Okej, jestem gotowy.
Dobra, stymulujemy.
Stop.
Oh, very nice.
Stop.
Very
Stop.
nice.
Just, I have to stop for... ja poproszę o rękawiczkę, dobrze się zsunęła. Mogę poprosić o rękawiczki jeszcze jedne? Bo, excuse me for a while, coat is too short for me and I have to change my gloves.
Having the data that cryoablation in some unusual or rare anatomies is still effective, there are more and more centers that do not perform any imaging before the cryo. And I know there are some different approaches to this pulmonary veins angiography. So, does anybody use that kind of injections or some selective injections with some other smaller catheters? What's your
I do it
approach?
selectively. Yes. One shot per each vein, and this usually consumes within 50 milliliters.
Well,
of
but in
contrast
this case, I
medicine.
think it was not
For all four-
really
For all four
necessary.
veins.
That's disadvantage of this approach that
Yeah,
you have to give quite a lot of contrast.
And you don't always get nice pictures.
Stymulację komory. Tak? Stop.
What do you do?
Yeah.
I usually do it like this. But it's very important to remember to withdraw the contrast from the sheath because its volume is like 15 cc. So it's like probably I give 20 for 2 injections, both sides. So it's usually enough to see veins on both sides. And then after the last injection, I withdraw the whole contrast from the sheath because it's quite big volume.
Okay.
Anatomy looks very convenient for the ablation, so you're lucky.
Ale górna jeszcze, wróćmy do tego
Agnieszka,
górnego.
pokaż referencję.
We see that the puncture is nice anterior. There's a long distance between the
Lot of
ostium of the
space,
right
yeah.
inferior
Już, nie, już
and the
jest okej.
kinking of the sheath.
Już okej.
Dobra, wracamy na Leo.
Ja muszę referencję zobaczyć, czy mamy wszystko gotowe.
Dobra.
Okej.
Do you exclude any anatomy from cryoablation or try every patient?
I
Even
don't
if-
have that comfort, but I curse myself when I have a long common os. That's
Okay.
actually the only anatomy that's
Looks-
feasible with this approach.
Dobra,
in my way.
jedziemy na Leo.
You can always isolate it distally, but that's not the point.
Yeah, but
Evil sits at the base.
Fortunately, data says that it's still safe and does not create any narrowing of the veins. Probably due to its
Referencję lewą. No.
there's quite big musculature in this common os. But yeah, after some redo cases, realized that this common os is not right.
Yeah, I had the same impression. I had to re-isolate it circumferentially more proximally, and that solved the problem usually.
Even doing circumferential ablation, that kind of osteologist make some a little bit different approach for deploying the line, right? More to the atrium and and this circle is in a different plane than usually when you're targeting separate ostia. So
Yes.
To jest kamera? Dobra, dobra, okej.
Ktoś z techników, kto tutaj pomoże? Ktoś od kryokonsoli?
Proszę podłączyć przewód gazowy, tak? Czy pan będzie mógł pokazać konsolę w czasie tego? Sięgnie pan tą kamerą na tamten ekran? Tam jest ekran za nami od kryokonsoli. On będzie zaraz potrzebny. Czy będziemy mogli go pokazać?
I Atrial.
Can we switch to live screen and fluoro for the beginning of the ablation? Because I suppose that you're going to use monitoring of the signals with circular catheter. Okay, there it is. I see that you're using the older version of the Atrial catheter, so I have a feeling that this new one is more flexible and it helps in difficult angles because the older version has a very stiff shaft, and when you try to target some difficult veins and you need to give an angle to the whole assembly, it's sometimes difficult, and my impression is that it's much easier with this new version of Achieve Advance.
How new is this new version?
How new?
Yeah.
I think about a couple of months, from the beginning of the last year probably. It's available.
So we have to talk with Kinga. That's.
Of course, it's not a very good idea to use it first time live. So I would prefer to do it on a regular way. There was such situation in the workshop in Warsaw last year. I think the operator get this catheter first time. Okay, so. Yes, and he got it for the first time.
Okay, Agnieszka, naciśnij, okay?
We see that you're about to start. And before you do, could you tell us what freezing protocol are you using? How many applications? How long? Do you ever give bonus shots? Tell us, how do you do it?
It depends on date of birth of patients. By the way,
That's a new algorithm.
What is what's date of the patient birth here? Okay, just I will tell you in a moment. Just
Sure.
that's because we'll have time during freezing to discuss it.
Can we see the live screen for on the left side? Okay. Beautiful rainbow.
Yes. That's quite jolly.
Dokładamy 75, nie?
Znaczy dokładamy 120 od czasu izolacji.
What's the signal augmentation on lasso? Because we can hardly see anything. Could we make it larger, the signals? We can see the PVP, but it's very small.
Okej. No dobrze, to możemy w takim razie...
Can we ask for the operator of the system? It's Anya probably, right? To give us a triggered mode and sweep speed for 200. Is it possible?
balon.
Inflacja, proszę. Czy ona jest... czy nie jest za głęboko? Ona tak...
Can we see fluoro again? Because the temperature is not important.
On nie jest jakiś tak nierozprężony.
Dokładnie, jakby ściągnijmy balon. Deflate balon.
Deflate and inflate, tak? Spuścić.
Deflate.
The size of the balloon was not I would say what we
Could
have.
we ask for
expected.
triggered mode
Now
for
inflating, please.
the
Na pełni, proszę.
intracardiac?
Czy nie, może to ten rentgen, co?
To może to jest kwestia, on dość głęboko wchodzi.
Or to the
We are getting deep.
right.
Anyway, I just have this feeling. The size of this vein is probably,
It's a big vein.
it's a big vein.
Probably
So
we can
it's-
get atrial
it
occlusion
is-
somewhere here. Just
We can assess it with what kind of signals we have in Achieve.
Musielibyśmy przyświecić, bo ją widział generalnie, gdzie jesteśmy.
okay. Now we can see nice
Okay.
PVP.
Yeah.
Can we go to the, well, our reference is there. Okay, we have the size of this vein. It's really, well, bigger than balloon. And it cause some.
It looks quite good now.
Okay, so let's try, let's give contrast, and then we will see what will happen. Okay,
Lewa górna.
okay, looks nice.
Small leak.
Small
somewhere.
leakage, but
Yes.
Small leakage, but we will, I think, may pull down this. And okay, so let's freeze.
Do you have any special technique for the big veins, or for
well, I
Special
try
technique?
not to push too much.
I will not push too much and then pull it down. So we will see what will happen, and then. But I will wait like a minute until we will pull it down.
Sometimes it's also useful to apply lighter push and after initial freezing push to push it
Yes,
more
yes,
because
because
the balloon gets harder and it increases
pressure
its
increases.
volume slightly.
That's
It
the
helps sometimes.
But okay, we will see. That's already minute. I will show you how it will look on the screen. I will pull it down. I don't know.
Nothing
We will
happens.
the screen. Nothing really happens. Yes, that's and it's basically temperature. It's
quite
that well. And I just wait because now I'm trying to push, not to. But okay, the size of balloon should be already bigger, and now pushing who might have
And it had effect on temperature. It's falling.
Yeah, and I don't see any move of.
And we can see delay in the okay. And now it's
Bravo,
gone.
100
An
seconds.
isolation, which is 100 seconds.
So for how
So
long
we
would
will
you
continue.
go?
Tomek, could you be that polite and explain what is protocol in this patient? Because Tomek is taking care for the.
So, in fact, we have two protocols depending on the on the fact if the birth date is I don't know how to call it in English.
Odd and even.
Yeah, exactly. And for uneven patients, we are adding 120 seconds to the time of isolation. And by the patients who have even dates, we perform only one isolation, 240 seconds. If the isolation happened before 75 seconds, if it was after, then we
Może troszkę boleć, ale.
240 seconds.
If it was after, then I didn't hear you. You do another shot?
It's after 75
75,
seconds.
it's
we
cut
give-
off. Yeah.
Then you will
On
give a
bonus.
bonus shot. And is this patient even or odd in terms of his birthday?
In terms of this, our little study, he's uneven, so we'll add 120 seconds to 100 seconds. It will be
I see.
220.
Okay. Uneven meaning the day when he was born is uneven, or you add
The year.
Yeah.
Like sort of small numerology. No, it's just
Randomization.
Zmniejszyć do 220. Do 220.
Okay.
5 sekund zostało. Jeszcze gdyby ktoś mógł
Proszę skrócić to do 220. Teraz. Okay. So this patient's out of protocol.
No, it's 220.
Exactly.
Exactly.
Okay, that's great. How you did it? But it works. That's great. And so you have nice isolation in this case.
Okay.
Can we come back to the moment in the system where those signals disappear? Just to show to those who haven't seen it. Idziemy teraz na dolną, tak. Can we inflate it again and deflate? Agnieszka? Gdzie ona jest?
Kinga, poprzez co? Inflację.
Tak? Jeszcze raz, bo nie chcę się schować, tak?
Dobra, i deflate.
Deflated, no.
Tak. Przytrzymaj stymulację bez bradykardii.
Dobrze, stymulacja jest ok. Okej, jest schowany, tak?
Przynieś Agnieszkę, jak dosyć na wszelki wypadek.
Atropina, tak?
Na wszelki wypadek przynieś.
Ale dobrze. Okej.
Nie, na razie przytrzymaj, bo tam zatoka panu nie wróciła. Pytanie tylko, czy...
A możemy zwolnić troszkę tą stymulację? Zwolnić. Tak? Tysiąc. Okay. So it's dobrze, wyłączymy. So it's somehow good sign because the mechanism what we're doing beside isolation, it's still, as you know, matter of debate. But basically, I always consider it to be a sign that we sometimes denervate patient, and it's and usually helps, I think. Okay, we go to the inferior. Can we? That's okay. It seems to be already there. Okay, can we inflate? Okay. So let's give a contrast. Well, it's maybe small leakage, but we will do the same as the previous one. Okay, let's freeze.
Do you routinely perform pull down in this phase?
Well, it depends on temperature, and it depends on signals, of course. But no, I would say not routinely, but when necessary.
Could we see the console instead of the X-ray?
They
Because
can
I
read
want
that.
to admire the temperature.
And signals are
Delayed.
So in this case, I will do this pull down. I will show you on X-ray because just to want to show that's and okay, it helped.
Okay, it helped
But
on
we will
temperature.
see what will happen with signal because
It's
I'm not
still there.
It's still there. No, but at least temperature.
A bit further.
Now, would you take a, in case it didn't disappear, would you take a full application?
Okay,
Oh, it
that-
disappeared, luckily. But if it didn't, would you take a full shot or would you interrupt after a certain period of time?
10 ustawmy. Kinga?
Sorry, to be honest, I did not understood
Okay,
your question.
if should this signal not disappear, how long
that's-
would you
that's
continue the
understood.
application? Would you take the full application or would you break
We
prematurely?
will try to introduce achieve little bit different branch and find little bit different angle, and then repeat the procedure from the different point and okay, that's until. Well, the question is how many times shall we repeat this procedure, which is a question I cannot answer.
No one knows the answer. So for how long are you going to continue this here? 120 above the isolation?
210 because in 90 seconds at the time of
Okay,
90
so always
isolation.
120. Okay, above.
What would you do if the monitoring of the signals due to anatomy of the vein is impossible?
If you don't see the signal.
If you don't see the signals, what would you do? Is it some standard application?
If you don't have any information from this conducting signal, we will use only temperature and time. So we'll do a regular application of 240, which is standard.
Would you then give a bonus shot or not?
Oh, well, again, it depends on temperature, but basically we would, if the temperature will drop, to 40, I would say, like 50, will approach 50, then not. But if it will be, be close to the 40, then probably yes.
I see.
But in this case, we will not repeat, and we will go to the right side. But, okay, we will make this.
So which vein are you going to start with on the right side?
Superior.
Superior.
Normally, we start with superior.
What is your approach, Alec?
I usually start with the inferior.
Same as me, because
The risk of palsy is lower.
Risk of palsy is lower. And do you think it's really
you're less likely.
Okay,
You're
all right.
less
No, no,
likely
no,
to leave one vein unisolated
You're
due to
less likely
persisting
to have a
pain.
complete
Well, okay, it's
procedure
logical.
before you develop the complication. If you develop the complication.
it makes sense. Okay.
We're not asking you to change your protocol,
No,
of course,
this
just
was a
discussing.
question.
No, it's not. Well, our protocol, it's not in this respect very strict. It's usually more convenient to start from superior simply.
Yes, that's true.
And did you make this?
Having that kind of puncture, the risk of, I don't know, dislodgement of the assembly to the right atrial is very small.
Yeah.
So probably there's no risk related to changing the.
Are you going to use the CMAP for phrenic nerve functioning monitoring?
Yes, that's exactly what we are going to do. And first, I have to dislodge this coronary sinus and to look if you have any, but it's. Może troszkę wyżej, bo nie wiem, ona się kończy.
Stymulacja sesji 1.
Ale to jest tutaj. Czy już stymulujemy, czy nie?
Nie.
Tak, tak, proszę. Wyżej, tylko ona nie chce jakoś tu się zagina. Tak jakoś. Maybe tutaj. Możemy jeszcze trochę wyżej z tym rentgenem podjechać, bo ja tak naprawdę nie wiem, gdzie my
Ale
jesteśmy.
już jesteśmy bardzo wysoko. Wydaje mi się, że powinniśmy szukać.
Już powinniśmy iść na dół, tak. Sometimes it's not very easy to find the place. No, so it should be. Oh. Now we have it. Okay, and now let's look at the signal.
I will see them on the first lead.
Okay, you will see them on the first lead here, and as I showed you, its right and left arm is well dislodged a little bit, and we have this very characteristic signal.
Yeah.
Like this. To be honest, I see it first time on the system, because usually we work on the other side in the second lab. So the signal, it's a little bit different to this. But let's see how it is. You see my movement, so we have double check. Możemy na rękę pokazać. And we will, let's look on the signal in the first lead.
Czy moglibyśmy troszeczkę ściągnąć w dół wykres pierwszego odprowadzenia, bo nam ucina górę sygnału CMAP-u?
Pani Kingo, możemy?
W ogóle
Czy tam jakoś, nie wiem, co tam jest? A nie, po pani,
Okay,
to tam
thank you.
jest? Ja nie widzę nikogo. Nie wiem, po pani. So, as you remember, the reduction of this amplitude for 35% would be indicative of danger of pulse. So that's
Right.
Let's go back. Wyłącz stymulację. Z balonem. Wycofajmy się balonem.
dobrze, dobrze, ja wiem, tylko on nie chce mi się tutaj, ale dobrze, okej, będzie okej. Okay, let's go to Atrial.
We can see that you're keeping your achieve outside the sheet all the time, so it's very important just to prevent damaging with the sharp edge of the steerable sheet and make some damage to the atrial wall. So it's very important that the person who's cooperator to remember to keep the catheter just out of the tip of the sheet.
Okay, we are in superior vein, hopefully, and let's have a look on signal. At signals.
I will have to be...
Can we increase gain? Oh, okay, so now you're probably won't be able to stay there.
No, that's a fat PVP.
But it's not that easy, yeah, but okay, I will.
Prawa górna. Tak, prawa górna.
Okay, let's inflate.
Nadmuchajmy.
Inflation.
Właśnie widzę. Okej, podaję kontrast.
Just a moment. Okay, can we make AP projection just because of this, what we have learned from the study? Where is the border of the heart? On the left on it, so it seems to be safe. Okay, come on. There. So, let's give contrast. Okay.
Some leakage.
Let's freeze. Yes,
Probably
freeze.
you'll have to pull down because there's something leaking underneath.
Yeah, still, but it's the leakage is very slow, so I
It
really.
might be successful.
You'll probably close it.
The device is really forgiving.
Stymulacja. Tak? Jest?
And it increases in diameter a little bit.
No. Yes. Dobra, okay. Still, we'll make double check because that's the trick with ECG is nice, but we are not, at least in this system, we're not quite familiar with this. So there's the signal. So at least I'm not.
They're clear right now. Okay, isolation.
Okay, it's isolated.
Okay, so let's make this calculation again.
180.
So in this case, I will not pull it down. It's already 40, and it's going down, and I really, that's right superior. Okay. It's early isolation. I will not touch it. I think that the angiovenography is absolutely one of the key points. I remember last year it was a case where Dr. Jastrzębski somehow refused to do it, saying that it's not necessary, and it depends on operator, but I would really recommend to do it. I don't know how it is with rotational angiography. Is it really enough to take one bolus? No, it would be nice to have it. However, we had this one abstract from I don't know which centers for assessment to ERA. And they compared this rotational angiography with this approach, finding no difference. But it was blinded, so we don't know which center it was. But it's reasonable big study. as far as time was concerned and radiation time, there were no differences, not only the outcome, in respect of atrial fibrillation.
Okay.
Okay. Mm-hmm.
There's no.
Okay, that's down.
Since we are.
Okay. Again, it looks that we are on vein. That's me. Okay, I will advance this. But can we don't achieve it? Niech pan spróbuje go jeszcze troszeczkę. Tak, cofnę.
Na tej tak musimy nadmuchać balon, zobaczyć, do jakiego miejsca. Nadmuchajmy balon.
Proszę. Okay. Nice. Oh, it was deeper, but okay.
Okay.
That looks well. Okay. Let's have a look on this. Just wait a little bit. Let's look at signals.
So.
Okay.
Very juicy.
All right.
So let's see what's happened. Oh, now it's okay. This inferior. No, that's perhaps
the
good
gap
candidate
is too
for
much.
pull down. Okay.
It's quite big
Okay.
gap. And
Yeah, it's rather big gap. Maybe we'll still try to improve it a little bit. Just like this, maybe. Oh, it's already pulling and then pushing. Okay, let's check now. I think it's little bit better. Okay, let's freeze.
Jeszcze chwilkę. Stymulacja.
when do you start pacing the phrenic nerve? It depends on temperature or time?
The temperature.
No, we have to.
-10.
That's
Okay.
no.
Odwróć.
Jest. Dobra, okay.
Are you freezing currently?
Yeah.
Could we see the console?
Can show this?
What's the
No,
temperature?
it's not that bad. It is better than we could expect.
Okay, may we see the console, please, the temperatures?
No, okay.
Okay, thank you.
Can we move a little bit?
There's some delay, but still conduction
Yeah.
on the inferior part of the
Yeah.
vein regarding the position of the
Probably
catheter.
because it's delayed. It must be infero-posterior.
Nie stymuluję przypomnę.
Dobra, niech pan to przesunie. Dobra. Za daleko, bo mi ręki nie starcza. And to is
So there's some
disadvantages of
disadvantage
the cabin. Then you have to have a very long arm to.
So we still see the conduction to the vein, so
Okay, that's the right inferior. It's well, sometimes more difficult than others. Ta temperatura się obniża jednak. Ja bym troszeczkę Okej. No, może, dobra, stop. Stop. Jeszcze poprawimy to. Tak, już pani trzeba.
Stymulacja.
Okej. It's not that bad. I would. Do we have any branch? No, it's well.
The problem with the vein is that there are no branches running inferiorly.
Branches.
It's usually
I try to go a little
troublesome.
bit down and to change the curve. Maybe it's when we go from inferior like this, and this angle will be different. Okay. But it's okay. Let's inflate it.
I would try now.
Some seems to be, but we'll inject some. Yeah, okay. But it's sorry. Once more. Okay. Oh, that looks great. Okay, so let's freeze.
In the case that when I have a small space for the balloon and the sheet, it's not the case here. I usually put like half of the balloon inside the vein and then inflate.
Okay.
And if it has the correct shape, of course, I inject immediately after the balloon is inflated, and it usually works in like 70% of the case. It jumped out probably due to it changed its volume,
Something's changed.
and it's
Yeah,
out.
okay.
Popped out.
No, but in this case, it would be kind of. You never know if you are not freezing vein. Or you mean that you observe the moment when it jump out and you try to keep it in this very moment, yes?
Yes, and of course the crucial thing is the shape of the balloon because
Znowu nie ma. Okay.
just to make sure that you're not the vein. But now probably your balloon has jumped out of the ostium when the pressure rised inside of the balloon. So
But I'm afraid that, it's something has changed, and temperature it's not that low than we expected, and
You've been much deeper initially.
I think so. But we made some maneuver with unstable electrode, or I don't know if it was the reason, but. Nie ma, niech pan to poprawi. Still we have problem with stability of this electrode. Once more. Okay, I think we will stop in the moment because temperature was too high and we lost our phrenic stimulation. So we have to fix it and then come back, hopefully, to the same position. Okay, can we stimulate just to... no.
Musimy wejść wyżej.
Ale gdzie pan... Nie, no
To
dobrze.
przeglądaj.
To w tym miejscu było.
Nie, wyżej.
Tak, no dobra. Jak wyżej, to wyżej. Grunt, żeby działał.
Teraz w ogóle idzie do jakiegoś łóżka, nie trzeba mi było.
Dobra. Proszę teraz postymulować.
Stymulujemy? Tak?
No. To wam się przez moment stymulowało, ale tu był takie miejsce, gdzie dość... Dobra, okej. Dobra. Dobrze, let's come back to this vein. We had a problem with stability of this. Okay. So once more, go down as we did last time and little bit. Okay. Okay, let's inflate it. Inflation, please. It was deeper, I think. It's not this position. So, okay, maybe like now. Let's check it now. Okay? I will... No. Dobra. Czyli ja cofnę się jeszcze z tym raz. Dobra. Let's deflate balloon. No. Okay, this is... we simply need to have different angle, maybe like this angle. It's still too high. It was like from this. Okay, let's check now. Inflate. Still, this is not optimal position. But okay, let's check. I didn't see anything. Okay, please deflate.
Okay.
I will try to get a little bit deeper, and we will check Bartek's maneuver. Is it suitable for this? Okay. Inflate now.
Okay.
Now the countries.
It's in
Do
the
you have
vein.
Freeze.
I think it's inside.
And
I think so. Well, maybe not. We would have to see the angiograms you did before to know that. Maybe it's not.
It's again out of the ostium.
Okay.
yeah, it's possible that it moved because it's...
It jump out. The same
Stop.
situation.
Jump out.
Yes,
Okay, stop. Stop. Przerwam. Musimy wrócić do tego miejsca, gdzie stymulacja jest skuteczna, ale aplikacja już miała, to trzeba jeszcze raz. Ok, zrobimy to jeszcze raz. Zobaczymy, na ile to jest powtarzalny manewr. Dobra, spróbujemy wejść głębiej z tym. Ok.
Maybe try to give some more support from the sheath. Bend it a little bit more and push towards the vein, and probably it will prevent jumping out, or maybe
You could
prevent.
also
Okay,
check
it's
in the LAO projection for correct alignment. Sometimes that's the
That's true.
answer.
That's true. And LAO, and now RAO, please, because let's go there. Okay, let's inflate. No, now it's deep.
But it still doesn't have any support from the sheath. Probably.
Yeah,
Okay, let's freeze. And I will look. I'm in the cabin, so Bartek is also partially in the cabin. Yeah, Bartek, Tomek, I say. So we are.
Stymuluj.
Now the position seems better and remained in the
Okay, we have good signals there, and this is.
spot.
temperature is also better. Okay, it's stable.
And
Pokaż jakie były na początku te sygnały. To było to, co widać? Aha, no izolacja była w międzyczasie.
to w takim razie doliczmy od 40, tak?
No teraz dopiero to zauważyłem, powiem szczerze.
Ale 40 możemy przyjąć.
Dobra, do 180 wejdźmy. 180.
Być może możemy cofnąć i przejrzeć dokładnie jeszcze.
Pokaż, Ania, od początku aplikacji, w którym momencie to było.
Could you show us the review screen? Because there are these signals on the distal achieve. Yes, it's probably in the atrium below the balloon.
Okej.
Dobrze.
To już jest w trakcie mrożenia?
Nie, na sam początek proszę pokazać.
Okay. Just for the information of those who are hungry, the lunch will be available only for another 40 minutes, then it will be taken away. So whoever has the fancy,
It's your chance.
it's your chance to get something.
Nie, Dobrze, a pokaż jakie są teraz może chociaż. Tak jakby jedna komponenta ubyła. Popatrzcie, jest tak, chyba tak. Tylko chciałbym, żebyśmy zobaczyli, w którym momencie ona ubyła.
Ale było poniżej 60 sekund.
No dobra.
Dobra, stop stymulacja.
Do you assess exit block from the vein as well at the end of the procedure, or the entrance is enough?
No we can.
W tym przypadku możemy to zrobić.
To niech pan tam powie, żeby ono to...
Nie, a możemy ocenić w takim razie stymulację z PV1 i PV1, 2, 2, 3.
What are the actual signals? Could you show us the live screen, please?
Can we...
Okay, probably. And can we see the position of the achieve? Because there's some interesting signal, probably not PVP, but...
Well, just wait.
Okay,
And this explain.
Can we have the answer?
I will go back with
I mean,
this.
it's from the atrium.
Yeah, it seems to be, but I will go back and maybe we will have better position of the chain.
And then it's D.
Now
Yeah.
we're convinced that it's isolated.
So maybe, well, if necessary, we will go to superior one, just to, but we have to inflate and deflate again. Can we?
It's superior. But we have to
Okay.
hide the balloon. Okay.
No, I'm afraid we, can I, well,
Dmuchajmy.
just inflate and deflate.
You can see some dissociated PVPs.
Deflate.
And deflate, please, yes,
Probably
because
just to
I can
bound
adjust.
inside the vein because it's not regular. It does not repeat.
Okay, teraz
Okay, let's go to LAO. Okay. So it's...
to be sure we would have to make stimulation.
And okay.
There are many more signals in the beginning before the first freeze. But of course, if you want to be sure, you have to do some differential. Amazing.
Can we have the reference? How was it? Because it made faster.
To musiał pan coś poświecić.
Okay. Co to jest?
Może znowu na ten kanał będzie.
Tu jest straszny odblask z tego światła z tyłu. Po prostu. Czy... nie wiem, czy ten... się nie daje przekręcić w ogóle. Nie, muszę coś stało. Czekać.
Okej. Zresztą teraz trzeba poszukać na wszyscy pójściu. Wśród gałęzi nie potrzeba. Trochę cofnij się i teraz powiedz zakończyć.
Okay. Is it enough? Or yeah, that's branch, I think.
Dystalnie byłoby lepiej.
You had nice distal position at the beginning of the procedure.
Oh, thank you.
No, it's better. Okay.
It looks good. Okay, I think we can stimulate now. It says you didn't. Oh.
Connect the catheter, please.
6-6. Wiem.
Can you?
Tomek, connect the catheter.
Tak, już wyłączę.
No, yeah, you have. But he did it already. Okay.
Nie wierzę. A jaka jest energia?
Well, try different place.
It is quite deep. We can see that that CS1 is faster than CS3-4. And you can appreciate conduction via Bachmann's bundle. And for the upper part of the left atrium.
Okay. Wierzę, to jest far field.
Okay, looks good.
Okay, can you measure this? Yes, but please measure this delay.
Stymulusa do tego far fieldu.
It's no doubt.
There's only one signal and it comes at the same time as CS.
Okay.
So
So
it
it's
must be appendage.
So we will go down to the last one. I hope it's.
Troszkę postawać, okej.
Still have some signals, but
Możemy przyświecić? Okej, przystymulujmy w takim razie jeszcze raz.
Well, we can do the same. Yeah.
The same thing.
okay.
Yeah, but its result is very similar. Okay, I think at this moment we will finish this procedure. If you have any further suggestion, we can discuss it. But basically, we would stop in this point.
Right. We are wholly satisfied. I don't know if anyone has any questions.
Probably almost everybody's on lunch.
Yes.
So, smacznego, dziękujemy pięknie.
Okay, dziękujemy.
No, Pan Aleksandrze, bardzo, bardzo pięknie dziękuję.